That's a little bit.
Rob, if we just give it one more minute.
Right. Need some background music.
Okay, Rob, I think the last minutes are just coming through, and then so we can start if you'd like to. Or normally.
I'll be starting. Shall I start? Okay. Good day, everyone, and welcome to this webinar hosted by the Lean Institute Africa. I'm Norman Faull from the Lean Institute. Before introducing our presenter, may I draw your attention to this housekeeping slide. So we're recording the webinar and your participation is taken as agreement to this. We'll provide a link to the slides and the recording of the webinar. Everyone will be muted at the start of the presentation to avoid disruptions. The webinar is planned for 30 minutes. There will then be a further 30 minutes for questions and or sharing of experiences at the end of the presentation. In order to ask a question or share your experience, please use the raise hand button on your taskbar, or alternatively, send your question via the chat function, which you should find at the bottom of your screen. Please, can we ask everyone to keep their questions or comments to no longer than 1 or 2 minutes to give everyone a chance to share. There are a lot of people on this webinar. Now, it's my privilege to introduce our presenter, Dr. Rob Campbell. He's the CEO of Nurture Health, operating 12 hospitals in 5 South African provinces. The title of the webinar, Mapping the Unknown. Rob, over to you.
Thanks very much, Norman. And really thanks for everyone for joining us and to the Lean Institute Africa for giving us an opportunity to air this discussion. And I just want to get there right there. The idea for this discussion really started early in March, just after the first person had been diagnosed with COVID-19 in South Africa. And we began to become aware that things were going to change and that we were going to have to learn and make new plans fairly swiftly in order to be able to cope with it. And I guess at that stage, we also realized that this was unknown waters, that we didn't know really where we were going, and that while there was a lot of guidance coming out from bodies like the WHO, the CDC in the USA, and our local NICD, that there was still a lot unknown about this illness and what its impact was going to be on our globe and on our country, on our healthcare system, and in our case, on our company. So as we got into that, we started to wonder whether there was any possibility that we would be able to look to see what other people were experiencing, how it was impacting on them, and how ultimately perhaps it would be possible for us to share our experiences, our ideas, our developments, and make it a lot easier for us to cope with what was coming our way. And through doing so, get to a point where we could have better outcomes for our company, for our nation, and for the globe. We realized that while we were learning quickly and had to learn quickly, that other people were going through similar experiences and challenges, and that we could almost certainly learn a huge amount by looking outside of our own company and looking to be able to share ideas with other people. So we started to talk with the Lean Institute Africa about that, and we got to a point where we have this webinar today. And I really wanted to stress that we don't see ourselves as knowing the answers and the solutions and being clever. Far from it. We're really looking to the community we're speaking with today to see if we can pull together a crowdsourcing virtual platform through which we can efficiently and effectively share our ideas and responses and gain from each other's presence and from a community. So there's this idea that it would be so cool if we could share, if we could look at the processes and standards that are being developed and not have to do it by reinventing the wheel every time. If we could find common pathways and practices, reduce the time that it takes to develop all of this stuff, and make sure that more of us are prepared when the surge really starts to hit our way. We wanted to know, could we develop checklists that would help us to get there? So we thought that a way to do this would be to start off by presenting a specific case, our experience. Once again, not to suggest that we know what we're doing, but rather to say, how has this hit us? And by way of background, in Talib's book, The Black Swan, he talks about the black swan event that arrives out of the blue and completely disrupts our lives, disrupts the way we've done things and think about things, and brings about a new reality. And he contrasts two worlds. The first of these is Normalistan, and the second is Extremistan, when all of the old rules are thrown out of the window. So I wanted to start off by telling you about our Normalistan inside our Nurture Health, a little bit about who we are and how we've responded to building our management systems to be able to cope with normal every day-to-day life. So we're a group that is very small. We practice in the private sector. We focus on physical rehabilitation and mental health. And we have a group of small hospitals, the first of which was born in 1999 with 55 beds. And over the years, we've grown to a point where we are now 12 hospitals, but they're all really small. We have a total of 538 beds at the moment. And we've grown by merging with other organizations, by acquiring hospitals, building new hospitals. And over this time, we've had to start to be able to integrate new hospitals into our system to stabilize what's happening in our environment and standardize the way we do things so that we can collaborate. And along that journey, we discovered the idea of lean thinking, management, and practice. And really were excited about what it offered us in terms of our ability to achieve what we wanted to do, and ultimately to build what we've started to call the nurture management system inside our organization. And the journey really started with a series of articles in the Harvard Business Review in April 2010, which was looking at fixing healthcare. And a couple of the articles started to talk about the experience of people in a number of hospitals around the world. Some examples were Cleveland Clinic, Geisinger Health, the ThedaCare healthcare system, Virginia Mason, elements in the National Health Service in the UK, and places from as far afield as Australia and in the East, looking at ways of using this management system called Lean. And we were intrigued about it and wanted to find more about it and what it could do for us. So one of the early exposures we had was to spend time looking at the Lean Institute Africa's series of introductory courses on introduction to Lean, introduction to A3 thinking, introduction to Toyota Kata, and finding out how these things applied not only to industry and the world of business out there, but that had been used extensively in healthcare. And we went on to meet people at the lean conferences and summits, and see in the literature and in books how much people had written about how these ideas had been applied in healthcare, and how in fact they overlap so closely the way we think in healthcare in terms of the way we practice medicine, the way we care for patients. And there was a lot of congruence between this management system and the practice of healthcare. Now, I don't have time in this 30 minutes to go over all those ideas, but what I have done at the end of the presentation, and I won't show these particular slides now, but I've included a couple of slides where I've referenced some of the books, some of the resources that we've really benefited from. I thought that it would be worth just leaving them in at the tail end for those of you who do download the slides later to be able to go and see where some of the ideas have come from. And I really have to say that we've stolen, we've borrowed, we've copied. None of this is our own work, but it's really helped us to cope and grow. And so specifically, there were two sets of principles that have been really useful in shaping our Normalistan. The first of these was described by Stephen Spear in a PhD thesis that then became a book, which was first called Chasing the Rabbit, and then subsequently modified to be called The High Velocity Edge. And in essence, Spear said that successful companies who are able to take on the challenge of a changing world really obey five principles. The first of those is they define the ideal, what perfect customer service and the achievement of perfect customer value looks like, and they know about it, they're clear about it, and they set out to achieve it. And they do that with the next four principles, which are, first of all, specifying and designing the work that they're doing to capture their existing knowledge of what is best practice and to be able to reveal problems in their system of delivery, standardizing. They are able to swarm and solve problems as they are seen, as they occur, and they don't allow things to brew and rot in their system. They fix them immediately, swarm and solve. And then they share their learnings as soon as they become apparent with each other across the organization. And then the last principle was that leaders lead not by standardizing, swarming and solving and sharing, but by developing those capabilities in the people in their organizations, so that we develop an army of scientific thinkers building effective systems that are agile and can adapt to changing circumstances, which really appealed to us. And we adopted that as a way in which we started to design model cells of how we operate and achieve things in our hospitals. The second set of principles that we adopted and really have been immensely helpful in shaping our response to the way we manage were the Shingo principles, coming from the Shingo Institute, where they talked about starting off by having a result orientation in terms of creating value for our customer. How do we shape our organization and our management structures around that? But then also starting from the bottom, trying to understand how we enable a culture of excellence, how we build systems that deliver continuous improvement, and how we align our entire enterprise upwards and downwards to achieve that great value for our customers. And so we really enjoyed what these two frameworks brought to our thinking and our approach to the way we started to manage our hospitals, manage our people, but also manage the way we delivered healthcare in our system. Along the way, we started to notice a consistent pattern that was emerging. It came out of the work we read from Virginia Mason. It came out of the Theta Care system that subsequently evolved into catalysis, the whole create value movement. And we found it really beautifully expressed in this schematic from a book by Pascal Dennis called Andy and Me in the Hospital. Really the idea that we are involved in the process of running our business and improving our business at the same time. And inside all of these stories that we were reading, there was a clear pattern of daily huddles happening at the place where healthcare was being delivered, engaging the nurses, the doctors, the therapists, the frontline staff in the process of understanding what was happening in the wards, the gyms, the kitchens, the offices, enabling them to solve problems at that level through structured daily huddles, and then where they couldn't solve those problems, escalating them to their managers at a hospital level, and where they couldn't solve problems or needed help, they were immediately escalating them to their executive team, and having information flowing up through the system, and also having coaching in terms of how do we solve these problems flowing back down through the system. And so during the course of 2018, 2019, we went through a series of workshops where we taught our people how to use this cascade of collection of information, solving problems, pushing it up through the system through a series of huddles and status meetings, and having coaching flow back down from the executive level down to the people at the front line. Always aligning ourselves around scientific problem solving expressed in the plan, do, study, adjust cycle, and also aligning ourselves around 6 core ideas that we believe and have come to believe express our ability to deliver value. And that those are safety, patient-centeredness, the way we look after our people, the way we do chase financial success, the way we look to bring brilliant clinical quality to our systems, and the way in which we use teams and teamwork to achieve all of that. And so throughout our hospitals, we've started to see the concept of the daily huddle at the coalface happening in a fairly consistent way. Here we've got a facility manager meeting with a case manager. And while we provided people with a model of how we thought things should happen in terms of a standard, we also encouraged them to innovate. This is another case management huddle board. And you can see it looks quite different from the fairly drab one we'd seen before, and really provided a high degree of visual management in terms of seeing where things are going well, where attention is needed, where problems are arising, and where things really need to be given attention to immediately. And we really asked for our folk to adopt and adapt the ideas that we were introducing to them. Some of the huddles were very small, but they're all clustered around the 6 spokes of value. We brought in the Toyota card and the coaching card. We provided cue cards on how they should run their huddles. This is the therapy team huddling at the beginning of their day, coming to terms with what their challenges are, solving the problems they've recognized over the last day, sharing their ideas with each other, and pulling things together. Once again, clustered around the 6 spokes and using cue cards and similar ways of problem solving. We were really excited when huddles started to move from managing our hospitals out into actually delivering clinical care. This is the team that was attending to this gentleman who had a spinal cord injury and had spent 5.5 months on a ventilator and had not been successfully weaned. The team used regular huddles clustered around the improvement and coaching kata to identify the obstacles that were preventing us from getting him off the ventilator and out and about into life again, paralyzed with tetraplegia, but at least off the ventilator. And ultimately, to achieve the value that he wanted, he'd really wanted to be able to get back to the beach. Yes, paralyzed, but off his ventilator and moving towards achieving a normal life. And for us, the idea of the huddles, the management system, this cascade of information and coaching up and down the organization really brought a lot of strength and consistency and agility to the way we did our work. So we really were constantly asking this question: what needs to be managed in each area, focusing on these 6 spokes and challenging our people to follow a consistent and systematic way of doing things. So that was all very well in Normalistan. And then on the 31st of December 2019, as we all remember, I feel quite responsible for this because the 31st of December is my birthday. And I guess I woke up seeing this news and thinking, look, this is probably not very important. But as we know, these first 27 cases of what has now become known as the COVID-19 illness have spread geometrically through the globe. The slide on the graph on the left is the one that Prof. Karim showed two Sundays ago. And shockingly, as we see on the 3rd of April here, we'd hit 1 million. Barely 18 days later, we're just clocking past 2.5 million across the globe. So this illness really has spread like a literal wildfire and started to disrupt nations and healthcare systems. And also, we're told, threatens to result in about 500 million people being pushed into poverty in the next months. This incredible cataclysm, this black swan that has really hit our globe. Of course, nationally, it arrived in our lives on the 5th of March, and we saw that initial fairly geometric rise in numbers, which flattened off at the beginning of the lockdown. And as you see on the right-hand side of this slide, while the numbers, the daily rate of increase was fairly erratic and a little bit higher in those first weeks post-lockdown, it has settled down to this range between an increase of 2 to 9% a day on a fairly consistent basis while we're in lockdown. And as Prof. Karim told the nation, we don't know exactly what's going to happen post-lockdown, and we can certainly expect it to surge. We've seen the numbers of tests being conducted increasing. It's now, in fact, clocked over 120,000, but we still almost certainly lag behind the numbers of tests we need to be doing. And along with the increase in the numbers, while we were initially quite excited, I think, to see that the mortality rate, the case fatality rate in South Africa seemed to be a little bit lower. In the last 4 or 5 days, we've seen that rising to almost 3%. So we certainly are starting to see an experience that very closely resembles what's happening in the rest of the globe. And we've seen a couple of models published in terms of what we expect to happen in South Africa. This is just one slide from a model that was developed for the private sector and only reflects a fragment of what is going to happen to the whole country. But in this model, there's a surge predicted from somewhere towards the end of June, with a peak somewhere at the end of July into August, and then a tail that settles down sometime in October and November. It's very uncertain, and we've heard the cliche that all models are wrong, but some models are useful. And certainly we've had the benefit of some models to start to plan and see what's going to go on in the next months, although we remain uncertain and we remain not sure of what's going to happen. So with that move from Normalistan into this Extremistan, where there was just so much uncertainty, and where the way we ran our hospitals, the way we practiced looking after people and managing the systems of care suddenly had to change. When we reflected on our 6 spokes model, we realized that in terms of safety, we were going to have to find ways of keeping the virus and the illness out of our systems, because we look after a very vulnerable population. If you come to physical rehabilitation hospital, you are already in trouble. Let's keep that virus away from you. We also realized that the time was going to come during the surge when we would have to respond and be able to look after people who were recovering from severe coronavirus infections. And how would we keep that stream separate? How would we keep them in while we were keeping the virus out of the rest of the hospital. We also recognized that this surge, this attack on the healthcare system, the capacity stretch that we were going to experience could potentially threaten person-centeredness, which has been so important to us in the delivery of care. How would we continue to support families, engage families, make it possible for families to participate in systems that were locked down in efficient systems of isolation and quarantine? We recognized, in terms of looking after our people, that they were fearful. We've seen a lot of anxiety. We've seen reports of insomnia. We've seen people wanting to stay away from work and living with uncertainty. And how do we empower, protect, and encourage them to make it possible for them to meet their obligations as healthcare workers? We recognize that this pandemic represented a significant threat to us as a financial system. We anticipated a drop in occupancy in our hospitals, and we've seen that. We've also anticipated an increase in the cost of running our service because of the need to be acquiring, providing, using personal protective equipment and running infection control programs at a much higher level. We didn't know what clinical quality was going to look like for patients with COVID. What do we treat them with? How do we treat them? How does that affect the way we run our hospitals? And how do we continue to provide high quality services for patients who are not infected with COVID in an environment where resources are being diverted to keep this pandemic at bay? And finally, in terms of our focus on teams and teamwork, how can we collaborate and learn from what we hear on a day-to-day basis? So having brainstormed our way through this, we first started to develop standards for the way we would approach this. We went off to WHO, CDC, NICD, looked at the guidance that they were giving us, and we started to translate that into what we call standard work documents, policies, processes, and tasks about how we are going to do things here. Infection prevention, screening, PPE acquisition and use, managing our supply chain, managing visitors in our hospital when we need to keep this virus out. And finally, how is this going to impact on day-to-day operations management? We started to produce documents defining those processes. We started to produce documents describing how you undertake various tasks, simple things like washing your hands, making sure that those things are being done properly by all in our facilities. And once you've written documents and published them on our intranet, they can be dead, useless tools unless you start to train people. And we started to use the training within an industry model, which has been described and used extensively over many decades as a really effective way of turning theory into practice. And while we, in many cases, didn't yet have the amount of PPEs in stock that we needed to be able to show people how to do things, we made a plan, used what we had, and got people practicing this so that the first time you were donning and doffing your PPEs wasn't the time when you were confronted by your first patient with this illness. We then moved on to look at how we could manage this on a day-to-day basis. And bearing in mind that we already had our level 1, level 2, and level 3 huddles and meetings happening on a consistent basis, we added a couple of elements to the system. And the first one was we introduced a daily COVID war room meeting, which was an executive and coach level meeting. And I'm going to tell you a little bit more about that. But before I come back to it, we made sure that daily war room meeting, which lasts for 30 minutes between 8:30 and 9 every morning, it links immediately in with a twice daily operations check-in, where we feed out the decisions, ideas, and countermeasures which we've developed inside the war room meeting to our facility managers in just 10 minutes twice a day. And we also get information from them about what's happening. So there's this very strong link between the daily huddle at the coalface and what's happening at the daily ops check-in. And then the last element that we introduced was a twice weekly town hall meeting. This meeting lasts for about 45 minutes to 60 minutes. It happens on Tuesdays and Thursdays over lunchtime. And it's really just an opportunity for myself and other executives to simply share what's happening to this pandemic, how is it affecting us, what are we doing about it, and how are we going to beat this thing. Really sharing ideas and then giving people at least half an hour to ask questions and have them answered in real time. And all people in the organization are invited to join that meeting, which is held on the Zoom platform. We're really trying to create an open, transparent environment for people to communicate with the executives from the coalface and have a conversation about where we are, express their fears, ask their questions, complain their complaints, and have that out. So with those in place, the war room meeting became the core of what we were doing. And we meet on Microsoft Teams for half an hour between 8:30 and 9. We chose Teams because we realized, and we'd been using Teams within the organization for almost 2.5, 3 years now. While there are probably better platforms that are more stable, that have better features, this was part of our Microsoft license. It was there already. And it combined video conferencing, file sharing, instant messaging and chatting into one platform where we could create, for example, a COVID war room team and use this one environment to communicate with each other on a daily basis. We also needed the ability to collect data and share it. We couldn't have a huddle board on a wall because we were, as executives, in 5 different cities. And we needed to share information in real time. So we've used Microsoft Forms to put together daily status questionnaires, which our facility managers fill in, and those upload data on occupancy, staffing issues, safety issues, and people issues directly to us, so that by the time they've been uploaded by the facility managers by 8:30, we can see what the trends are, respond to them, recognize problems, find ways of solving those, and then communicating back to the facility managers in the twice daily ops meetings. We also recognized that some of the things we initially built into the status questionnaires were redundant. We had an existing dashboard that we could track things like occupancy and nursing hours, and that could come to us without wasting the facility manager's time and over-processing. And we also realized that we could tap into resources like Power BI, also from Microsoft, to analyze data that we had within our database and start to understand patterns, for example, of what kind of diagnoses and diagnostic groups were being referred to us in the months between January and April, and how was that changing, and how was it going to change our response to what was happening. We came up with a bunch of problems. I'm not going to go through them all, but as the pandemic and our response to it has evolved, we've identified problems. Screening at the front door was initially done in a very lackadaisical fashion until we had to confront our people and remind them of the danger that was on the way. And so over time, we've started to recognize the need to develop different countermeasures for different problems under different circumstances. And we're still going to have to do that throughout the course of the pandemic. And so looking back, the sharing we have today is that we were fortunate in that we put in place a management system that we were able to lean back into to start to troubleshoot problems, start to close the gap between what we were doing and the new standards we were setting for ourselves, start to set new standards that were higher than we'd envisaged before, for example, in terms of infection control and the acquisition of PPEs, and how we could push our teams to rise to the occasion. And as we move forward into the next 18 months to 24 months in a COVID world, how is that going to reshape healthcare and the way we need to be practicing in our system of care in this country at this time? Now, zooming out from our specific experience, because this is really not about our organization, this is about how we can learn from each other as a community. We then look back at the kind of the overall plan that Prof. Karim had offered the nation 2 Sundays ago in terms of these stages of our national response to the COVID crisis. And we recognize that inside this, there are a bunch of problems that we're fighting together, whether I'm in the public sector or the private sector, whether I'm in one hospital group or another, whether I'm a solo practitioner or part of a group practice somewhere in the country, we're wrestling with the same issues. Those issues probably revolve around, but they're not limited to, issues of infection prevention, person-centeredness, caring for the people doing this work, ensuring financial success, whether you're in the public or the private sector, achieving budget, not wasting resources is important. Achieving clinical quality and making sure that we deliver on what we need to deliver on. And finally, really pulling teams together, because this is not something we're going to do alone. We need to pull people together and share our resources, ideas, and strengths. So it was at this point that we came back to Norman and Samantha at the Lean Institute Africa and said, what can we do together? How can we share our ideas with other people? And how can we, as Nurture Health, benefit from what other people are doing? And how can they maybe also benefit from some of the things we've learned? If we do this together, we're more likely to succeed. So Norman, that's where we got to the point where I guess we start this discussion. And this, what I've had to say is really just background.
Thanks very much, Rob. I think we've all listened with a certain amount of fascination and terror and admiration. So let's go to questions and comments. Sam, will you manage that?
I will manage it. I haven't received any questions via chat as of yet, and I don't see any hands up.
So I guess from my side, the question is, if you're listening to this, if you're participating in this, I guess you must have an interest in these questions. You must be grappling with these issues. Have any of you found things that are useful to you? What questions do you have about the problems that face us as we move to deal with COVID? Would you like an opportunity to share those and ask those questions?
Rob, Peter Milligan would like to.
Hello, Peter.
Say something.
Hello, Rob. Good to hear from you. Can you hear me?
I can hear you beautifully from KZN. I hope you're safe up there.
Yeah, thank you. Rob, just before we get into sort of way forward and that sort of thing, a question from your talk. Are your hospitals going to be actively managing COVID positive patients, or is your primary orientation here around keeping COVID out in that sense? I asked that question because I think that we here, for example, at Ngwelezan are a designated level 1 hospital for COVID. We've already had ICU admissions, but at the same time are trying to manage a non-COVID population within the same facility. And that's further complicated in my field of psychiatry, because with behaviorally disturbed psychotic patients, we're having to really think very, very carefully about infection control in that environment. So I just think that it's quite helpful just to get clarity on whether any of your facilities are actually actively managing COVID positives at the present time.
So Peter, it's a really important question. And I think that one of the realities that we had to come to terms with very early is that whether we like it or not, We find ourselves standing on the beach in Thailand on Boxing Day 10 years ago. The tidal wave is on its way. We really have no option. We are going to be involved in this, and we must prepare for it. In fact, Peter, we've already had our first COVID positive patient in one of our mental health care facilities, managed in and out of the hospital, and really by providence more than by skill, without infecting anyone else, and smoothly managed by the team at that hospital, partially using our standard work, partially using our practice, but partially by I think by luck. So patients are going to find their way into our hospitals, whether we want to or not. That's a fact, and we need to be prepared for that. And secondly, we're going to need to find ways of preparing, of caring for people who are COVID positive, while keeping the non-COVID positive population safe. And what we're reading from places like South Korea, China, Taiwan, is that people are separating patient streams. They're using different populations of healthcare workers, different geographical areas in their hospitals where they are able to do that. And sometimes they're defining a COVID positive hospital and a non-COVID positive hospital. So we're looking very hard at how we do that. And our hospitals, as we speak, we've got some hospitals which are pretty much like a submarine. It's a tank. It's a small building. It would be impossible to separate streams out. But there are other hospitals where we've got 2 or 3 or 4 different wings, and we could very easily create a completely separate stream of care for patients with COVID, as long as we're practicing meticulous infection prevention, meticulous flow of materials, food, garments, etc. And we're not cross-pollinating from one stream into the other. Peter, we don't know how we're going to do that. I want to be clear about that. This is why I asked for this discussion. But we know that if we engage in this discussion and we start to lay down standards, we're more likely to succeed than if we simply allow it to hit us without preparation. I don't know if that answers your question.
I think it does, Rob. Thanks for that. I think you introduced an important idea around different facilities managing in different ways, and the potential to manage differently across facilities. Because I must confess, in the public sector, certainly here at the moment, it feels a little bit like every man for himself. So, you know, these conversations are happening largely just within facilities. And there's not been a lot of conversation about how to manage things more broadly from a systemic point of view. And I think that I'd be very interested to hear more about that from your organization's perspective.
Rob?
Yes, sir.
We have a few more questions coming through. Okay. Can I go ahead, or are you going to comment still?
I'm going to cycle back to that, Peter. I just wanted to hear what other folk are saying, because I think it's an important one, is how do we coordinate and make strategic decisions? Because if it is every man for himself, we're probably not going to succeed as much as if there's a coordinated response. And how do we do that with a public and private sector that just don't talk to each other? And even inside the public sector and the private sector, we don't talk to each other. And this was our hope to get a conversation going on that. Sam?
Just on what Rob has just said, I've shared a link via the chat function. If anyone does want to register interest in what Rob is talking about, I'm sure he will come back to that later. Rob Grace has made a comment, more than a question. Accessing PPE as a solo practitioner has been very challenging.
I think that's being polite. We've seen shipments of PPEs stopped at the border and confiscated by government at times. We've seen people fighting with each other for PPEs, outbidding, outstripping. We've seen some dishonest practice in that area. And we've seen people rise to the occasion and start to make, fabricate, and produce items across the country. There have been some amazing stories about people building systems of care and PPE production facilities. I don't have the answer to that. And I really want to make that clear. I don't have the answers. So please don't look to me for them. But if we could get a discussion going, and perhaps there could be a group within this, perhaps some of the supply chain people within Lean could give us some advice on how we could go about coordinating this. I think there are a number of responses that we could look at for small solo practitioners all over the country who are going to be confronted by this illness and will find themselves unprotected unless there's a coordinated system. So I wish I had an answer or a wise solution, but I don't, except that we should be communicating about it.
Thanks, Rob. A question from Lucy. How do we ensure we still maintain high quality of care for our key populations, HIV, TB, while intensifying the response to COVID? In other countries, there is mention of declining facility attendance by people with HIV.
Yeah, this is a terrifying one, because if you are a vulnerable person with a chronic illness, whether it's a communicable chronic illness or a non-communicable one like diabetes, hypertension, someone on treatment for cancer, and you are facing this crisis. In our own system of care, most of the people we look after in our rehab hospitals are older than 70 years old. Most of them have diabetes, hypertension, have had a stroke, have had ischemic heart disease, have some form of impairing neurological disease, and are really the kind of people who should not be getting COVID. And how do we keep them safe? Once again, we've been thinking in terms of this keeping it out, keeping it in strategy. We've been thinking of streaming people and ensuring that we don't mix the geography, the healthcare workers, the streams of care in any way to keep people separate. And we've also looked at systems of proactive contact tracing. So if you come into one of our hospitals, we're looking at quarantining you on a precautionary basis for the first days you're with us, while we trace your contacts, while we make sure that you haven't been in contact with anyone who's had COVID, knowing that we're probably not going to get it right all the time, but the more times we get it right, the higher the level of safety will be. And perhaps as testing changes and as we learn from everyone on this discussion, maybe we'll find better ways together of identifying patients at risk of having this illness and keeping them away from people who are at risk of having this illness. I don't know if that's a good answer, but it's the only one I have. And it comes back to saying, please, can we get a discussion going about this so that we can explore better ways of doing this rather than leaving it to us to fight each problem by ourselves.
Thanks, Rob. I have another question from Heather Tuffin. I'm wondering about the scope of the sharing platform. Are we talking healthcare, including non-hospital facility-based services, healthcare facilities, or broader than health, wider coordination with other role players, civil society, DSD, etc.?
I feel like I'm the wrong person to answer these questions, because I feel like I'm the one who would like to be hearing the answers. But I guess we're going to beat this pandemic in public health and not in hospitals. And so there's a sense in which we need to be engaging civil society, unions, organizations who are working in our communities to educate our people on how to practice social distancing, make it possible for hand washing and sanitizing to happen, get the masks out there into our communities, get contact tracing and testing going. Those are things that don't happen in hospitals, and that's where the battle will be won. If we rely on our hospitals to fight this pandemic, we will lose, because we have, I believe, respectfully, while there's some wonderful people within public and private sector, we have a healthcare system in both public and private that is frail and teetering on the edge of functionality. We have to beat this in our communities. And how do we do that? In communities where taps and toilets are shared, where there is overcrowding. And these are issues that are beyond the realm of me as a doctor or as a manager of a set of hospitals. but I must look to those solutions to protect us and to give us a chance to do our job right. Heather, I'm not sure if that answers your question.
Sam, may I speak?
Please, Heather.
Yeah, so Rob, thank you. I think this is very exciting, and you echo my thoughts as well around this is going to take a sort of much bigger approach than just healthcare, and certainly than just facility-based services. I do also recognize, though, that we need different forums to be able to talk about different things, you know, so to have a group that's sort of saying, what are you doing for ward-based care, and how are you, you know, what are you doing to access PPE and stuff is very worthwhile. Equally, having a citywide, all role players come, let ideas merge and problems be solved by each other, you know, that sort of thing. So I'm quite excited about maybe a couple of platforms that could be sort of hosted maybe here, that, you know, that at one week might have a very granular focus, and another week might have a let's zoom out and just sense what's going on in society, and groups, and invite NGOs and churches and you know, those sort of role players into the discussion.
Yeah, I completely echo that, Heather. I mean, you know, at the moment I face a particular challenge. I've got 650 plus people working who I'm responsible for keeping safe. And one of the things on my mind is, how do I keep them safe? I'm going to keep them safe by getting the community problem sorted out, getting the ducks in a row in our communities so that we can prevent this. But once it does hit our hospitals, inevitably, I'm still going to need to keep these people safe and keep our patients safe. And how do we do that? So that there's this constant zoom in, zoom out approach. And I guess multiple forums, how do we manage that? We do have other jobs to do as apart from having these discussions, but could there be multiple platforms looking at different issues with people moving between them? I'd really love to hear what everyone has to suggest, and I'm happy to go along and be on the bus rather than the bus driver.
Thank you, Rob. Matt John has said, hi, is there a possibility that the supply chain comes home to SA during this? I think we have really been exposed by being reliant on imports, specifically for PPE. This makes a great opportunity for manufacturers in SA. And in just response to this, Melanie has said, VWSA has already started setting up a PPE producing initiative.
So I'm not in production or fabrication, but I know that we have colleagues in Swaziland who have a large and inactive population of people in the textile industry who would love to be making gowns and masks and gloves for us, but can't get them across the border. And there must be people who could start making PPEs for us locally. How do we set about doing that? And in a way, while today's discussion is about healthcare, and we invited people from healthcare to the discussion, I'm sure there are people in lean production in South Africa who could rise to help us. And how do we connect them with the right people? I don't have those answers. I'm part of a little group of hospitals doing a very niche thing, but looking out into our nation and saying, we're only going to succeed if we do this together. And where's the platform that we connect? What does it look like?
Alan Ben.
Okay, hi there. Can you hear me?
Yes, hello, Alan. Thank you.
Hey, hi there, Robert. Robert, I'm a structural civil engineer. One of my clients is the Tygerberg Hospital. So I do a lot of engineering for hospitals. As you've been talking, my mind's just been firing off in all different directions. There is honestly so much to talk about. And I think the beauty is getting different skills, people who actually think differently together. You talk about beating the pandemic, and I'm coming from a different angle, thinking, well, pandemics come and go. If it's not this one this year, you'll have another one next year, and the year after, and the year after. You did touch on taps, there not being enough taps, and infrastructure is what we need. And I think as we put in infrastructure, we need input from you guys. What should we be doing? And in terms of getting the right people together, my dealings with the Western Cape Department of Health has been very encouraging. They are putting teams together. And I think a discussion, you, myself, the architects, the engineers, the people who are running and managing hospitals, it might be useful to carry on something. The other thing is, as a department, as a company, we're working now remotely. It's a complete different way that we're working. We've had to set up systems. We've had to set up this new Normalistan, put in systems and procedures, and admit that we're probably going to have to change those procedures in a few days' time when we realize we're going in the wrong direction. What really has been useful is having a humble leadership, competent leaders who can listen, and humility comes through strongly in every successful thing that we've been in. And also to engage enthusiastically with all ideas, to be attentive and respectful to ideas, because you never know where the bright sparks are going to come from. There's a lot more. I'm just going to stop there, but if we can chat further, I think there are quite a few topics to explore.
Thank you, Alan.
Rob, Lauren de Kock.
Yeah, thank you. I work in the public sector, and I'm actually an advisor in the National Department of Health. And I just a couple things. What has struck me as well over the last little while is how agile our systems actually are. And I think for all of us who have maybe been in health for a long time, and specifically in public health, we've seen how rigid the system is. And all of a sudden now, in the era of COVID, I've been struck by how quickly the wheels can actually turn. And the lens, the psychology of change has really governed so much about what we do and what we say we can't do, simply because we're not willing to, or we are not trying to work together quickly. We're obviously putting lots of efforts in place to try and decant patients from facilities, make it a lot more accessible for people so that they don't have to go to facilities. This is something that we've actually been trying to do for the last few years with some form of success. But now all of a sudden there's this massive galvanized effort behind it. And I have to say, I sometimes am shocked by, because I'm not sure how altruistic these motives are. And I'm wondering why all of a sudden now there's this galvanized effort when it's something that we've been trying to do before. And I think that's really something that we need to take into account, is the motivation as to why things are moving so quickly and are actually able to move so quickly. Another point that I wanted to make was, I think that the government has set a good example over the last few weeks about how private and public can work together. And when I say private, I'm not just meaning healthcare. No. I've been very involved in the whole screening campaign and sourcing the devices that have been distributed to thousands of healthcare workers and setting that whole process up. And it's been great to be able to see the different industries come together and be willing to be part of a solution. And I've never seen that before to this great extent. But once again, it's possible. And so I think that we must build on those platforms. There are already a lot of fantastic networks that have been created. There are already a lot of bodies that can make decisions very quickly at the moment and we need to build on those. I was also involved in developing the pamphlets that have gone out to healthcare workers around the country. And very quickly, we needed to identify printers, we needed to identify designers, etc. And we could overnight get those businesses opened up. We could get things delivered to different provinces simply because government was behind it, government understood it, we were speaking to the right people, I was on the right platforms, and we were able to make these things happen. So I think it's about this coordinated effort where we're bringing the different industries together and ensuring that on the right platforms where decisions are made, whether we're forming subcommittees or within those committees, we must not try to form parallel processes that disregards the government process, because obviously the government processes is what's going to reach the vast majority of our country and where the real power lies in order to make some of these changes that gets the will and the spread. So I just wanted to make a couple of those.
Thanks, Lauren. I mean, I think clearly government, I mean, I'm not sure if everyone's going to agree with me, but I think our public health response has been incredibly powerful and leapt into action very quickly and has been effective. But how do we connect that coordinating role from National Department of Health, provincial departments of health together, and with the thousands of individual practitioners who could be contributing, and not only healthcare practitioners, but as you say, people who are out there in industries that support healthcare and support public health, the NGOs, the civic organizations, the unions. How can they become part of a single movement that carries that way forward? I don't have the answers, and I'm not. You sound like you're wonderfully positioned. You sound like you're someone we should have in on this quite closely. But you know, it's that communication, coordination, sharing thing that feels really important here.
Thanks, Rob. Howard?
Thanks, Rob, for a wonderful presentation, which is already giving us some ideas. Mine, I suppose, is a bit of a comment and a reflection. So in the COVID pandemic, what we have seen in the healthcare space, I manage a healthcare system in the private sector, is the movement of healthcare professionals from anxiety to fear. And I suppose going on, there will be post-traumatic stress disorders related to the activities that people are involved in. And in a country, certainly in my own specialty of maternity care, where there's very few specialists to go around, we shall have to think very carefully about how to leverage existing expertise, which is already in short supply. And so I think it's an area where I hear, and I'm assuming there's mental health specialists here who can tell us on what we should be thinking about in terms of mass debriefing of people, balanced groups using technologies like Zoom and Teams and ETC and so on and so forth. And I suppose my question really is there anything in the international literature where we can rapidly mobilize people and give therapeutic interventions at scale? Because this is going to hit us, healthcare providers are going to die. And I suppose you might not have the answer, and I'm posing it as well to the mental health specialists on the chat.
Howard, thanks. And I certainly don't have the answer. Because we do some mental health inside our hospitals, my colleagues, Marissa and Francis, have been working with our team of OTs, social workers, and psychologists to put together virtual programs that we can put out to healthcare workers, and specifically ours at the moment, because we wanted to look after our people, is to have debriefings, to have education sessions, some kind of group counseling sessions, so that we can look after our people. And we recognize the fear, the anxiety, and the lack of knowledge as being paralyzing factors that could really undermine our ability to perform right and really leave people with poor quality of life. So I think that is a focus of how do we care for the psychological safety of the people in healthcare has to be a big issue that someone has to take on. And if it could be shared, it's likely to reach out further.
Thank you.
Thank you, Howard.
Thanks, Rob. Seppo?
Okay, great. Thanks, Rob, for the wonderful and great presentation. I want to ask, I just read this interesting article published on the Maverick. It's a class of 93 from UCT, medical class, and they are saying that the ongoing hard lock is going to cause more damage in the long term, given that we are approaching winter season, and it's inevitable that the epidemic will reach a very significant percentage of the population. I remember even in the US, I think they estimated about 70% of the population are going to get affected or will actually eventually get this COVID. So I don't know if you've seen that article, because what they are requesting they're saying that the hard lock down is going to impact rather ease the lockdown so that we can start dealing with what is coming. We're just delaying the inevitable. What are your thoughts and comments on that? Thank you.
So, I think I want to pass that one on to the profs from the business school, because they're probably better placed to answer questions of economics and planning than I am. I don't know for sure whether we should be lifting it now or not. What I do understand is that we have bought ourselves some time. Whether that time is going to be weeks or months, whether it's going to be July or August, or I think it varies on how soon we go back to opening up the community. That's going to bring its own risks, and how it gets managed. That's above my viermark plek, as they say. What I know is that I've been given some time to prepare within my sphere of influence and control for a better response than we would have been able to do 4 or 5 weeks ago. And the question for me and to the people I work with, and I guess to people who are listening here who are in healthcare, is what are we going to do with the time that we've been given? I'd be interested to hear, Seppo, what more economically minded people think of an early lifting of the shutdown or not. But with whatever time I have, the question I raised in bringing this discussion to the table was to say, how can we use the time we have most effectively so that we prevent it as much as possible, even when we open up after long lockdown? And when the surge arrives, how can we win ourselves the highest degree of luck by being as prepared as possible? That's where I'm coming from. And I don't know if Anton or someone else who has a greater understanding of economics could answer the question of a sooner or a later return to opening up.
All right, thank you.
Thanks, Seppo. Sorry I couldn't answer your question. Yeah.
Rob, we are 7 minutes over time. I don't know if you want to quickly wrap up and speak about, how we move forward.
Sam, could I make a comment before we go to Rob?
Sure.
Rob, I'm no economist, and what I'm hoping is that as people are modeling the virus, its spread, its demand for ICU beds, etc., there are people modeling the economy. I also saw that article this morning and thought every point that they raised had validity, but did it have data? It's an opinion. And so I really want to go back to Lauren's contribution. Lauren, I think that your contribution did two things for me. It said we need groups like this sharing their common problems, but it also said the the issue is a national one, and there needs to be, what it amounts to is the government has got to be involved. If we go all the way to the way China dealt with it, we have a centralized government that simply makes the decisions, does not have to worry too much about a private sector input and response. All the controls, all the levers are in the hands of government. I'd really like to hear your comment, and I see your hand is up, as to the extent to which we should simply wait to be called on by government or government agencies to share inputs, or to what extent smaller initiatives should go ahead. Yeah, Lauren, I don't know if you've got a comment on that.
Norman, I just think in general we shouldn't wait. You yourself have so many wonderful connections with the Department of Health and so many wonderful insights that can contribute to these various platforms. I think it would be a travesty if we sat and waited for invites. I think that little groupings like this already connects me with people I've never connected with before. It helps us to start little platforms, and then to hopefully those platforms lead into other platforms. I think I don't know, I think it becomes absolutely crucial for every single one of us to see how we can take our level of influence and influence it somewhere else. How do we build onto that? How do we ricochet that? How does it become that knock-on effect? And I think that government requires all the different inputs and the expertise that so many people have in the private sector. And so if we identify a forum, how do we take it up with the various people and say, look, it's great that we've got these ministerial advisory committees, but maybe we want to look at something that deals specifically with implementation at facilities. And there are, Jürgen is heading up that COVID response team, and I know that you know him. So yeah, I don't know if it's what you're looking for. I don't know if I understood your question correctly, but I think there's a lot that each of us can do and must do, and not wait for invites.
Norman, you're on mute.
You're on mute, Norman.
Sorry. Lauren, thank you for that. I think it's very sensible what you're saying, that we can't wait for someone to invite us to participate. And so we must try what we can. What works will get some traction and contribute, and what doesn't work will die. And we need to have that humility to try stuff and stay with what's working and drop what's not working.
Rob, there are a few more questions, but I'd like you maybe to just talk to the last slide, and then people that need to drop off can drop off, and we can go to the last few questions for anyone that wants to stay on.
So in the discussions I've had with Sam and Norman, we wanted to propose a fortnightly virtual meeting like this, but not with myself or anyone else necessarily presenting, but where people who were participating in the discussion could forward topics or ideas that they would like to have questions answered or ideas put forward. The members could vote out of a selection of ideas put forward on 2 or 3 topics, and we could maybe take 10-20 minutes per topic and have a discussion about it, and walk away with some sharings and learnings from each other, create connections and relationships, and explore that as a forum to move forward with. And we really wanted to say that if you are interested in, there's a link which you can see here below in green, which Sam is going to post out with the emails in follow-up to everyone who's attended this webinar. And I guess it'll also be on the Lean Institute Africa website at some point. and that if you're interested, click on the link, join the group. If you don't like it, you can leave. We won't keep you forever. But, you know, we'd really like to involve people who could contribute, who'd like to contribute, and people who also would like to hear what other people are doing. So please share the link with your networks, let other people know that it's there, contribute if you want to, don't if you don't want to. But we'd really like to see if we can float this as an idea to move forward with and learn from each other.
I've also put the link in the chat function, and as Rob said, we will be emailing it out, and it will be on our website.
So if you scroll up to the top of the chat function, you'll see that Sam has put the link there. You can click on that and sign up straight away if you want to, or wait for the email, or look for it later.
All right, should I carry on with questions, and whoever has time to stay on the group can, and everyone else can leave? Maria says that there are 3 very important things we have learned, in the UK. 1, ask for help from all the community, i.e. schools making masks, etc. Number 2, do not underestimate the impact this will have. And number 3, test as many people as possible, especially healthcare workers.
Yeah, I agree.
Jackie.
Hi, hi there, Sam. Yeah, thanks, Rob, for a great presentation. I was listening with interest, and I agree that I think we need to move ahead and not wait for things, but make sure that we use the information that's out there and the experience from other countries. I was just listening to a webinar from some people in the front line in Italy last week. And one of the things that they talked about was, do not send us long, big policy documents. Send us a one-sided, one that we can see, that we can pin up on the wall, that we know what to do. And I think it's really critical to make sure that we're giving people the right information, because there is so much misinformation around as well, both for healthcare workers and also for the community. But making sure as well that systems are in place, because one of my fears is that there's a lot of knee-jerk reaction and we're not embedding systems that will sustain the improvement. I mean, like Lauren was talking about how the services actually managed to respond incredibly quickly, which is excellent. We just need to make sure that those responses are sustainable. What they found in the UK was that, for example, they managed to discharge a third of their long-standing patients that hadn't been able to be discharged, but they were sent home into the community without any support.
Yeah.
So it's making sure that some kind of systemic support, I mean, like standards and stuff, that will help that. But I do think there's a great opportunity for having people from different sectors, different professional groups as well, who've got different thinking, that we don't miss any opportunities. Thanks.
So thanks very much, Jackie. I mean, I think we really have felt the panic to do everything today. And then we've had to retreat from that and say, well, we can't. So this week we'll teach hand washing and donning and doffing. Next week we'll teach this. Next week we'll do that. We're probably not going to get to everything, but if we can embed some basic systems and start with the ones that are most important first, we're hoping that will bring us that luck that we're looking for. Through having the system entrenched in who we are and how we behave. It would be nice to do it faster and to have some things that we could take off the shelf rather than have to develop from scratch. And we're hoping that other people are feeling the same and that we can share those experiences and ideas.
Thanks, Rob. Heather?
Hello, Heather. Maybe.
Sorry, got it. So I was saying I have a default at the moment when I'm trying to decide whether to share or not to share. So excuse me if this isn't the platform. But I wanted to share that I'm working with a group of people at the moment. We fairly early on, I just started going, I can't see, I don't understand what's going on in all the different systems, even in my own system. And so I chatted to a couple of friends who've got fingers in all sorts of other networks. And what we're trying to do at the moment is we realize that people have responded and it's necessary that everyone's sort of doing what they can do, but there's a need to start coordinating and aligning those efforts. And so what we're trying to do is leverage existing networks and tech to actually start being able to allow, so we've got a couple of initiatives where we're doing a hashtag map your city that's going to come online in the next week or two, that will allow people to sort of put themselves on the map, but also search for different resources on the map in their area, from a big zoom out to a zoom in, and different role players. We've also realized that sort of information for certain groups is better formatted in a directory format, so we're looking at how to do that. We're also looking at some existing technologies already developed for matching need. So when somebody needs something, they can put out and find the people who can actually match that need, whether it's food distribution, whether it's maker spaces being matched together with health facilities, or whatever the story is. So I thought I'd just mention that because I'd really love to be able to use this network as well as a spreader of that when we actually sort of get going with the user aspect of it, to say, hey, are you on this map? Do you want to be part of this directory? Here's where you fill it in. This is where you find what you need to find. And then also maybe as a preliminary, for those of you who feel like me, that you can't see, what would you want to see? Who would you want to be able to contact? What groups of people, what services, that sort of thing. And maybe you can feed it to me and I can start making sure that those things are also included.
That sounds great, Heather. Sounds like an incredibly valuable, potentially very valuable resource. It'd be great to have that. Where do I find a mask? Where do I find a... Yeah. Thank you. Thanks for sharing your email. Appreciate it greatly.
Just if I can mention, I'm not going to read it, but in the group chat, there is messages from CGI Creative Graphics and Indigo Brands, just talking about, you know, what they do now, and they actually have repurposed their manufacturing, so they're offering masks, etc.
Thanks, guys.
If anyone wants that. Heather has posted her email on group chat as well, if anyone wants to contact her. Rob, I think that's all.
Can I ask the last question?
Go for it.
Rob, what I think is also brilliant is your 6 focus areas that you put up as part of your True North. I think, when I listen to what you said, I think you've answered it, but I want to ask it directly. In this period that we're in, do you see these 6 areas having the same weight, or how, if you have to say which one is your most key one in this period, or yeah, how do you see the weighting of the 6 focus areas that you have there?
So Chepo, I mean, the immediate obvious impulse is, of course, it's safety. and it should be, it has to be. Our safety is threatened. I mean, it's perhaps just important to just remember Paul O'Neill, who died, I think, yesterday, and his emphasis on safety at the beginning and end of every meeting he ever had at Alcoa. And his emphasis on the dignity of people, on respecting people. So we have to keep people safe. But in our work over the last 3 or 4 weeks, we've swung from focusing on safety to focusing on looking after the psychological safety of our people, to looking at occupancy, because if we don't keep our beds full, if we don't find a way of filling up our beds, it's all going to be irrelevant because we won't be here. But if we have full beds and they're full of COVID, then we also won't be here and we'll be damaging people. So it's kind of, we need to measure the data every morning and see what today's burning issue is and solve that problem as the one thing we can do today. And then tomorrow there'll be others, but we always come back and start off with safety. How do we, where are the safety issues? Where are we at risk? What do we need to do? What can we learn about what happened yesterday? We have a tracking sheet. Every time we come up with a shop or facility that's shut down around one of our hospitals, we're handing that out to all of our people, and we're learning more and more about how to educate people to look after themselves. And so, sorry, bad answer, waffle answer. The short answer is safety probably is the number one thing at the moment, but that we have to buttress safety by looking at what the data tells us today, responding to those problems, and then coming back tomorrow and just constantly being on our feet and looking to see what we need to do next.
No, great, thanks. Because that's exactly what I thought. Because what I see is that safety actually is the one that allows that will enable the others. Because if your staff is safe, you are able to do the rest.
That's why we really put safety at the top of that set of 6 things, and it's something we really have prized and valued. If we can keep our people safe, if we can keep our patients safe, then the rest of the things will happen after that, and excellence will follow.
Okay, great, thanks. Thanks so much.
Thanks, Campbell.
Hi, it's Anton here. I wonder if I can sneak in a last comment. It struck me that underpinning all of our conversation this afternoon, it comes down to the scientific method again, about experimenting and getting rapid feedback and trying to speed up that cycle of experimentation. But I just thought it's interesting to note that there are also experiments at a very grand scale on the go at the moment, and partially in response to Tsepo's question about the article. Apparently in New Zealand, they're experimenting with completely eradicating the virus, apparently or probably because they're able to control their borders. But at the other extreme in Sweden, they're experimenting with no lockdown. In other words, developing herd immunity. And unfortunately, sometimes the scientific method takes a bit of time, so we won't know the answer to those 2 experiments for some time, but it's just worth noting that they are trying to find those answers. And thanks, Rob. It was a really great session this afternoon.
I really want to thank everyone for participating. It's been really enriching, and thinking about it has driven me back to think about important issues and recognize them. So I'm really grateful for the opportunity.
Thanks very much, Rob, and thanks everyone for being part of this, and let's take this forward. Let's sign up on that link and identify the topics and put our minds together as we take this forward. Thank you.
Great. Thanks very much, everyone. Thank you.
Bye, everyone.
Bye.